You'd think that at VMR number, I don't know, 700 for me, I think, was crazy. I should reflect on why it's VMR 700 for me personally, or close to that. You think that I'd be any less excited having done this more than 700 times, but I'm so excited for many reasons. I think the most apparent reason it's a double first. It is a first kind of time case discussion and a first time case presenter. Both people are people that I've gotten to interact with extensively in VMR, so I'm so jazzed. When I get excited, I get carried away, and I constantly telling myself to remind you all of the new initiative that we have for those of you watching on YouTube to really encourage you to join us live. So behind the scenes, we have Academy sessions that are happen in frequency, double that to the amount of VMR. We usually have many sessions varying in duration from a few minutes, like I did yesterday, to an hour, like a couple of sessions we've had in the last 48 hours or so. We really want everybody to be part of this community. And to show you what it's like, we host a 15-minute Academy session right before the VMR tomorrow on Friday. So you will see the esteemed Jas Bajwa co-discuss with myself tomorrow. And if you're inclined to see his smile, now I'm forcing him to come 15 minutes early. Who knows if he's actually able to make it or not? But if you wanted to potentially have the chance to see his beaming smile 15 minutes early and learn from a really cool case that I have saved just for that time slot, I hope you will consider joining us. You'll just use the same link to the VMR. And if you haven't signed up, now's your chance to do so. You just go to our website and sign up. So I look forward to seeing some of you. And I really encourage you, if you're unfamiliar with the Academy, turn your video off, tell us about yourself. That's another time to get to know you a little bit better. But today we have a guest case presenter who I would love to hand the mic to before I introduce everybody else, because Lucas has been part of VMR, the VMR community, for a long time. So very excited for your first case. Lucas, maybe for those who haven't seen your face or heard your name, likely more so not here, but maybe on YouTube, tell us a little bit about yourself, please.
Hi guys, I'm Lucas. I would say I'm a med student in the fifth year, and yeah, I've joining like the VMR sessions for 1.5 years, I think. And unfortunately, not in the academy, and I was so scared. I wasn't the right case, and now I regret that I haven't done it prior to this. But yeah, finally the day have come to present my case. Yeah.
Yeah, Lucas, it's against all my internal policies to tell you, but don't worry, we're going to rectify that last statement ASAP. Worry not. Um, Yeah, we're very thrilled to have you. I will say that whenever Lucas makes a comment in the chat, I know it contains either the path to the answer or the answer itself, so I try not to look at it to bias me. So he's a diagnostic wizard, and very glad to be here with you, Lucas. Um, it's also a first for Siva, who also needs no introduction. I got to know Siva simply because he was actually turning his camera on, gosh, probably almost a little less than a year ago, so consistently and so regularly on VMR. And he made an absolutely emphatic uh, impact on Kirtan and I when he presented a case of a patient who had a complex cryptic, long-standing evasive syndrome that had to do with a little tiny gland in the brain. And I was so humbled by the way he told the story, because I later learned he didn't actually see the patient. He was putting it together for somebody else. And so naturally had to invite him into the academy, and he's just been an ever-present, consistent, dedicated human being in this space. And yeah, if Siva's not there at an academy session, you wonder if he's physically doing okay. So it's been such a treat. This is a long day coming, a long time coming, excuse me. So I'll hand the mic to you to say hello, and then of course we will introduce the supporting cast making the session happen.
Hi everybody, I'm Shiva. I'm an IMG from South India. I'm currently based in Buffalo. I'm really excited and at the same time more nervous right now at the session. So
Yeah,
hopefully, yeah, it'll go well.
it'll go well, 100%. Don't you worry. It'll go absolutely well, because the whole goal is just to practice and learn and develop. So it can, by definition, cannot go bad. And I think we'll have a great time because we have two VMR veterans anchoring the session, beginning with Magnus, who's scribing.
Hello, everyone. Super excited for Lucas' case and Siva's discussion.
Amazing. Thank you so much, Magnus. And just a little south of you, both on Zoom screen and in real life, I'll hand the mic to Julia for teaching points.
Hello, everybody. So excited for the case, and I hope I can distill down what how rich the case is going to be because I have to agree. The input we got from Lucas in the chat is just phenomenal. So I'm a little bit extra excited today, and Tio, you'll do great.
No doubt about it. Thank you so much, Julia. All right, Lucas, we're ready to rock and roll whenever you are.
Okay. Thanks, guys. So this case is 6 aliquots, with the last revealing the diagnosis. And I saw this case in my first emergency rotation. And yeah, it's about a 75-year-old male who presents to the ER with the chief complaint of retrosternal chest pain and vomiting. The patient notes a history of reflux and involuntary hiccups. He described the reflux as intermittent episodes of retrosternal burning sensation with no radiation at all. It was difficult for him to say if there were certain exacerbating or alleviating factors or to describe it further, but he just reports managing this on his own without his general practitioner. And he said he was usually able to eat and keep things down without issue, but for the past few years, it just has been more and more hiccups and there was no clear trigger to this. And the day prior to his presentation in the ER, the symptoms were a bit more bothersome than usual, and he didn't feel like eating much. And despite this, around midnight, he had 8 episodes of non-bloody, non-bilious emesis. He otherwise reported feeling well, without fevers, chills, no dyspnea, cough, no swelling anywhere, or rashes, no diarrhea, nausea, abdominal pain, dysphagia, constipation, headaches, dysuria, or any other symptoms. So he thought it would just be better on its own and really preferred to stay home, but it was actually his son who persuaded him to come to the ED. And his family was there, and his accompanying family gave a little different story. They were quite worried about him and his symptoms.
Mm.
His son noted significant anorexia over the last 2 weeks, barely eating, while his daughter reported significant weight loss over the preceding 6 months. When you asked the patient about these concerns, he just reiterated he was doing fine. I stop here for the discussion.
Lucas, it's unreal what you've just done. You painted a picture of a really fascinating syndrome, but also painted light on the person who's bearing this disease and their relationship with their illness, as highlighted by the stark contrast between his own perspective and his family's perspective. This is a seasoned person taking a really high quality history. Siva, I think if I'm putting myself in your shoes, I imagine you probably have 100 million thoughts, and it's probably so hard to organize it. Um, and so let's try something, I think, a really good skill to try to first kind of slow down that excessive thinking, which I'm presuming you have. Odds are you do. And just try to hear how you're summarizing not analyzing the information, but summarizing the story. So what have you uploaded about this person and their illness so far?
This is an elderly male with a chronic history of
Mm.
vomitings, like hiccups, vomitings, and chest pain, who had an acute episode like in the last 2 weeks with weight loss, significant weight loss over the last 6 months.
Superb, superb. I think that is a really powerful distillation of a lot of data that you have. And my analysis is just the same as yours. There's chronicity to it, as evidenced by the weight loss. You can't lose weight quickly, but then there's obviously a hectic new dimension to this syndrome proceeding over the last few days or weeks. So, where is your mind inclined to start to analyze what's going on?
Um, I'm thinking like his retrosternal chest pain with hiccups for that chronic illness. I'm thinking something which is hiccups. I usually think of something irritating diaphragm. So
Ugh.
in this case, he has vomiting with chest pain.
Mm.
So I'm thinking some kind of mass, and there is a weight loss also.
Mhm.
So there is some kind of mass which is causing all these symptoms. Could be that. So an imaging would be a good thing for
Superb.
this patient. That's where I am right now.
It's such a advanced thing that you're doing that you're saying that I've said this before on RLR CP solvers, and I think it's true. Medicine really comes down to two S's. I know Magnus might disagree, and he likes the four S's of pancytopenia, which I highly recommend you check out the episode that also featured Simi and Manaswini. But I think there are two S's fundamentally. Either there's a substance that is driving illness, like a medication side effect, or there is a structural issue happening in the body. And from that very simplistic perspective, I'm so impressed by your analysis because you're saying the patient has such prominent focal symptoms that you can point to an area in and around the diaphragm that easily explains chest pain and easily explains vomiting. And in general, if you're trying to figure out does the patient have a substance issue or a structural issue, if you can point with your finger to where the problem is, odds are it's not a substance, and odds are it's a structural problem. And so your ability to realize that and fundamentally say that you could get a medical history, you could do a physical exam, but the major branch point in this patient's illness is, can you visualize the structure or is it going to be difficult to do so? I think that's orders of magnitude of clinical leaps, but you might speculate on what you might see with the data that we're going to get. And so I agree with you. I think imaging is the cornerstone of the evaluation, but let's see what additional data Lucas gives us in terms of the context and the exam to see what is that? What is the nature of that mass and where might it be to fine-tune our pretest probability? Awesome job. All right, Lucas, Mike to you. Very, very intriguing.
Okay, so for his past medical history, he has hypertension and gout, and doesn't really see his general practitioner very often. The last time years ago. For his meds, he takes enalapril and hydrochlorothiazide and allopurinol. Other than that, nothing. His family history was non-contributory, and social history, he's a retired truck driver, lives alone. His wife died about 3 years ago, but his children check in on him regularly. No recent travel or sick contacts. He has 3-pack-year smoking history, but he quit many years ago, and no alcohol or illicit substance use. For his vitals, he was afebrile, 36.8. He was a heart rate of 80 per minute. Blood pressure was 118/61. Normal respiratory rate, oxygen saturation on room air 97%, and BMI of 24. His exam, general, he seemed normal appearing, not in acute pain. You notice sometimes like the hiccups, which came at some points. Cardiac auscultation-wise, he had a systolic murmur, which was loudest at the right upper sternal border and the left fifth intercostal spaces in the midclavicular line. And there was no radiation to the carotids, no JVD or anything. Lungs were clear to auscultation bilaterally. So then the abdomen, he had sparse bowel sounds. And there was, when you came into the room directly, there was a visible mass in the right upper quadrant, approximately the size of the palm of my hand. And it was very firm, but painless on palpation. There was no overlying erythema, warmth, or fluctuance. The patient wasn't sure how long it had been there or he hadn't noted it. The remaining abdomen was soft, non-tender, and non-distended. There was no guarding, but while palpating his abdomen, there were again those intermittent, spontaneous, non-painful contractions. Like I had the feeling there was musculature, and the patient hiccuped again. There was no CVA or costovertebral angle tenderness, and no signs for appendicitis. Skin, there was no peripheral edema, no lymphadenopathy, no jaundice, no erythema on the palms, no rashes, no telangiectasias, and the neuro was within normal limits as well. I stop here for discussion.
Oh, very, very astute exam. Both your observations in the moment and also studying what's happening as the patient evolves in front of you with the contractions. Really interesting. So, Siva, you had a hypothesis. I'm curious, what do you think of the additional data now? Oh, I think you're muted. What a shame. Uh,
Sorry.
Yeah.
Uh, uh, I don't know what kind of mass is it. Is this? It said they mentioned like it is firm and painless. So I'm thinking like some kind of lipoma, some kind those like a fat tissue can be or something. I don't know whether I can say it is a hepatic liver mass. So that is a possibility. And regarding the systolic murmur, yeah, usually when I see systolic murmur in old patients, I think like it is a physiological murmur. But his vitals 118 over 60, so the pulse pressure is little bit wide.
Mhm.
So I don't know whether there is any valve issue like AR or something which can be.
Mhm.
Uh, so that is something that I'm thinking. And rest of the conditions like
Mhm.
no, I don't know what to like. Everything seems normal apart from these.
Yeah. You know, Siva, one of the hardest things about intern year is struggling to disentangle what is signal and what is noise. I think what you're illustrating to people is your ability to study the signal and discard the noise is very powerful. When people are earlier in their training, they feel inclined to analyze every single piece of data, but it's actually higher order thinking to disentangle this puzzle into the elements that you've identified. And I think a wide pulse pressure essentially tells you that the cardiac output, which is the difference between systole and diastole, is making a big difference in this patient's blood pressure. And the question becomes, are they having a super high cardiac output, as would occur in aortic insufficiency, or do they have a normal cardiac output but really stiff vessels? And the stiff vessels do not absorb the pressure, instead transmit it. And when they transmit it all the way down to the brachial artery, the pulse pressure is high. And when a patient you see a wide pulse pressure, you can reinforce that hypothesis by seeing that they have chronic hypertension. And that tells you that they probably have stiff calcific aortic vessels and potentially even calcific aortic stenosis based on the murmur. And so that is by far and away the most common cause of wide pulse pressure. So odds are that that is noise. I agree with you that it certainly stands out, but in a clinical scenario where the patient is on two blood pressure medications, odds are they don't have a serious valvular issue or serious compensatory increase of cardiac output. In stark contrast, the significance of this issue is now heightened by the fact that you do see a patient with two blood pressure medications who's visiting you in the emergency room with a normal blood pressure. That might be because he took his medications, but might reinforce the idea that his family is emphasizing about just how hypovolemic he might be. And so that's the significance that I draw from it. I think how you analyze the mass is really powerful because if you do see a mass on the surface of the body without overlying skin changes, I think you make a simple assumption. And that assumption is to try to distinguish between a malignant invasive mass and a benign simple mass is the behavior of the mass. And we make the assumption that a mass with uh, poor intentions and sinister objectives, like a cancer, would continue to grow and therefore influence the health of the overlying skin by making it ulcerate, by making it bleed. And so I think it's very wise of you to say the fact that there is no overlying skin changes and the skin appears healthy makes me wonder whether this math is intrinsically not a malignant process. However, the health of the skin certainly seems to be intact, but what about the other side of this mass, the internal side of this mass? And that's where my concern for it is augmented because I agree with you that it doesn't seem to be causing consequence on the surface. But you already proposed this idea that there is a structural peridiaphragmatic process that is causing problems. And a gentle, non-invasive mass would have no symptoms at the top of the skin, and importantly, no symptoms on the inside of the skin. It remains to be proven whether the internal aspects of the space-occupying process are causing structural issues, or the patient has a separate structural problem and an incidental lipoma. But you can start to see that if you have to think, oh, there's an incidental lipoma and a separate process, you're invoking two parallel hypotheses when they could be simply united by one process. So, what do I encourage you to use from this aliquot? It's to reinforce your instinct that if there aren't any concerning changes on the skin, then the mass is more likely to be benign. But I also encourage you to upload the mental model to study every side of this mass up and down. And if below the mass there are symptoms suggestive of visceral disease, that might help us adjudicate the calculus of what this mass is. I can't speculate any further on the origins of this mass because the patient doesn't have any obvious localizing symptoms like jaundice, for example. So I'm open to this mass being originating from Manny structure. But I think it just reinforces what you said, which is imaging, imaging, imaging. Um, so yeah, we have a lot of work left to do. I know we have 6 aliquots in total. So let's hand the mic to Lucas to tell us what happens next.
Okay, great discussion, guys. So the labs, he had an elevated white blood count, 18.76. His MCV was normal. He has hemoglobin of 11.5. I will put the labs into the chat for better overview. Platelets were elevated, 696. His sodium was 135. His potassium was 5. Chloride was within normal limits. We have unfortunately no BUN. Creatinine was elevated, 2.39. We have a baseline creatinine from 18 years ago, which was 0.83, so normal limits. Glucose was 165. Calcium was normal. AST and LT were both elevated, about the 90s. Alk Phos was elevated with 193. Total bili was not elevated, normal limits 0.29. Total protein was a little lower, 59 grams, but one line. Albumin was same, a little bit lower, 39.3 grams per liter. PTT and PT were normal. Troponin was elevated too, 43. Normal limit is under 14. CK was normal. TSH was normal. LDH was slightly elevated, 259. Lipase was normal limits. The CRP was elevated with 181. Normal limit was under 5. Ferritin was elevated with 696. Transferrin saturation was a little lower, 10.9%. Vitamin B12 was normal. Folate was a little lower, 4.2. And urinalysis was not significant. But I put all those values in the chat.
Because thank you for the crystal clear enunciation of the labs. Yeah, Siva, I'm curious what you're making of this data.
Uh, I'm thinking because of that mass, this patient is not able to eat from a long time, and even his hydration status, like for instance, in this patient, he has a creat of 2.5 with baseline zero point 0.8. So I'm thinking in the last 2 weeks, the patient is not drinking enough, and which led to AKI. And his anemia is also his TSAT is 10%. So he has iron deficiency anemia. Along with that, he has chronic, like a ferritin is high. So he has anemia of chronic disease as well, and which with the folate and vitamin B12 values reinforces that folate value. And he is having inflammation going on right now because his WBC is high, and his uh, thrombocytosis he has high. There is some inflammation going on with
Mm,
like underlying
mm.
decreased PO intake. And yeah, and
Yeah.
his LDH is mildly elevated, but
Yeah.
still I think of malignancy as well in this patient, still even though it is mild.
Yes.
So that is where I am.
Yeah, brevity is the soul of wit, Siva, which is the fanciest way to say that the less you talk, the more you know, which I definitely don't do, just FYI. But you're clearly demonstrating. Um, Maybe I can ask you 2 follow-up questions to your analysis. I'm curious, how does the presence of thrombocytosis add value to the presence of leukocytosis? So leukocytosis equals inflammation, but when you also see thrombocytosis, what additional value does that give you?
I think like thrombocytosis basically most likely it is reactive thrombocytosis in most
Yeah.
cases.
Right.
So in this patient, I don't know, for this patient I can attribute two reasons. One is iron deficiency anemia itself can cause thrombocytosis,
Good.
and second thing is like infections or
Good.
yeah, that's what I can think of.
Excellent. I'm going to try to show you something that I think you already know in the back of your mind, and I'm going to try to make it conscious for you. So, in a patient with acute pneumonia, I see leukocytosis a lot. How often do you think I see thrombocytosis in acute community-acquired pneumonia?
Not much.
Yeah. So take that and analyze that. So what does the presence of thrombocytosis do for us in this situation, you think? Just, I know you have a lot of other data, but if you just focus on the thrombocytosis, what is that telling you here? We don't see
Just
it in acute. Yeah, go ahead. Sorry.
I mean I can't think of anything except for inflammation going on. It's
Yeah.
like a reactive process,
And do
but
you think
it can be
acute,
due to sorry.
acute or subacute inflammation?
I'm thinking in this case I'm thinking more of subacute
Yeah,
inflammation.
right. If you didn't, you already knew that, right, Siva? You already knew it was subacute from the history. But
Hmm.
part of getting as much juice out of the labs is to ignore the history for a moment and see what they tell you. And this thrombocytosis tells me the family's right, not the patient. Because you don't know, right? You don't know where the accuracy of information is coming from. You're like, this is going on for a while. So it's incredible how you already knew it, right? You said pneumonia. No, I don't think so. Acute pneumonia. So the presence of thrombocytosis confirms the idea that this is a subacute process. And I think, for example, this is not going to be a simple pyogenic infection. The only way this is going to be a pyogenic infection is if the infection formed and it made a capsule, i.e., an abscess. This is not going to be Staph aureus bacteremia. This is going to be Staph aureus bacteremia if there with a liver abscess, right? So I think that this is a marker of chronicity, and so really advocates. And you found other markers of chronicity. You found anemia of chronic inflammation as an example. So just want to emphasize what is the value of the platelets here? They're not meaningless because you already get the value of inflammation from the leukocytosis. The additional contribution of the thrombocytosis is to give you a time course, and that time course is subacute to chronic. So now, Siva, a second follow-up question is, I'll enumerate all the things that you said, and let's put them in the category of cause or consequence. And I'll give you an example of what I mean. So you said hypovolemia. I would propose that that is a consequence of the cause, not the cause itself. And so I'm curious, what are you doing with the iron profile? What are you doing with the inflammation? Are you putting them in the cause or consequence category? What do you think?
I'm thinking consequence because of that mass he's not eating and because of that hypovolemia and AKI.
I agree.
So mass is the primary issue.
I agree. I think the tension in this case, Siva, is what do we use as a clue to help us understand this mass? And what do we discard as a consequence of its existence? So what tells us, this helps me understand this mass? I think if the inflammatory markers were all normal, there would be almost 100% chance this is malignant. The presence of inflammatory markers opens the door to the possibility of an unusual infection, but there are unfortunately many cancers that also have a inflammatory phenotype. So the presence of the leukocytosis and thrombocytosis complicates things because it opens the door to an alternative hypothesis, but that does not eliminate cancer. And I think the main question is, now that we have that inflammation making our job a little bit harder diagnostically, the question is what to do with the iron profile. Does it tell us that this patient is bleeding and therefore is the patient, sorry, iron deficient, and therefore iron deficiency is bleeding? And does that tell us about the potential origins of this mass involving the gastrointestinal tract? Or is this merely a distractor telling us the patient has anemia of chronic inflammation, which, as you said, offers no uh, clue to the underlying mass? So for me, if I'm being transparent, Siva, I think hypovolemia consequence, inflammation clue, clue to either cancer, which would have been almost 100% if there was no inflammation, versus uh, hidden infection, abscess or granuloma, And then, oh my gosh, the iron profile is tantalizingly in both categories. It could easily be iron deficiency and a profound clue to the origins of this mass in the gastrointestinal tract. Alternatively, it may be an utter complete distraction and maybe just a consequence of the chronic inflammation. And I think that is difficult to completely disentangle. But uh, we are being internists and we are scratching our chins too much. If this patient was in my emergency room, I would tell myself, stop thinking and start doing. This patient needs a CT scan, as you said from moment one. But I'm really curious, what any questions or clarifications I can share with you about that analysis?
No, nothing at the moment. I like the way you organized everything for me. Thank you.
Hey, it's about 10 years of doing this. You should learn one or two things along the way. I'm happy to share some of it with you. All right, Lucas, what do you have next?
Awesome discussion, guys. Next is diagnostics. We have ECG, chest X-ray, TTE, and abdominal ultrasound. I will only show you the abdominal ultrasound by sharing the picture, but for the ECG, was a sinus rhythm with a left bundle branch block, and it was unclear for the duration, and we have no prior ECGs to compare to, unfortunately, but there was no ST elevation or T wave changes. The chest X-ray was complete in normal limits. And for the ultrasound, I hope technically I can share the picture for you. Okay. Uh, Give me 1 second.
Take your time. There's no rush at all. It's a great time to tell you that I have no idea how to read ultrasounds. You could tell me that this is a baby, and I would believe it, honestly.
Can you guys see the screen?
Yes, yeah, we can see it. It looks great.
I have three pictures in general. You just can say when I put the next one up, and yeah, feel free to discuss.
Siva, unfortunately, even though you flattered me and complimented me earlier, now's the time, my time to not shine. I have no ultrasound interpretation skills, which I'm happy to confess. So I'll lean on you to tell us what you think, and you feel free to also imply.
I am scared of imaging in the first place, and I don't know.
Yeah, amazing. I see we actually have an expert in the house. I don't know, Ravi, if you're able to unmute and shed light on what you're seeing. That'd be really cool. If not, no worries at all.
Oh, hi.
Hi,
How are you? Sorry,
good morning.
good morning. Down with a little cold, but
Oh, I'm sorry.
wonderful to hear Lucas present a case. He's always sort
Uh,
of stealthily in the background. But yeah, what I'm seeing here is that this liver, see the sort of hypoechoic, isoechoic, sort of on the left, you see the whole liver, and
yeah,
then you see the circumscribed towards the middle, sort of cystic-like
I
structure.
see.
And it's got anechoic pattern and then isoechoic pattern with content in there. But at the lower pole, you see this sort of hyperechoic
Hmm.
signal, and behind it is a shadow. We call that acoustic shadowing. So that just means that the material likely is calcific, and so it
Mm,
it um, it reflects all the sound, and behind it, there's
I
no
see.
sound getting penetrated, so there's a shadow. So it's sort of like a solid structure, which could be a stone, but then there's all this messy stuff in the middle, which could
Right.
be cellular debris or tissue,
Fascinating.
and that's it. Yeah.
Yeah, I mean, you brought it to life. Siva, do you have any questions for Dr. Ravi before he goes?
No, I don't have any. Thank you, Dr. Ravi.
Yeah.
Thank
See,
you.
this is the beauty of this community is like you have so many people around to enlighten you. I think we have experts in every single domain. That's awesome. Yeah, you have a couple more pictures, Lucas. Is that right?
Yeah,
Amazing.
basically.
Yeah. Yeah, feel free to go through all of them. This is number two, I think, right? Yeah, okay.
Yeah.
Interesting. Okay. Um, Maybe Shiva, we can try to analyze this data now. It seems like uh, I forgot what other. I was so distracted by the ultrasound. So it seems like we have an EKG with a left bundle branch block, and then ultrasound with this finding, maybe some other things that I forgot. Yeah, what happened to your thinking as we got this information?
I'm thinking like as Dr. Ravi mentioned, it's a calcified mass, and this patient has this chronic history. So I'm thinking, can this be like chronic granulomatous disease kind of thing, like calcified mass? That is something that I'm thinking. And about LB, left bundle branch block, many people they have their I want to know his baseline kind of thing. So it could be his baseline,
Right.
or if
Yeah.
it is new, yeah.
Another excellent distillation of signal versus noise. I think, of course, this patient could easily have aortic stenosis, endocarditis, and be inflamed. Very possible. Realistically speaking, he's not giving us a story that his problem in his heart. He's telling us a story is in his right upper quadrant. So we'll still have to keep an eye on that, but I think I'm right there with you, discarding that finding temporarily and studying the mass. And I only have one real piece of advice at this juncture in time, which is resources are a big issue in medicine. And so ultrasounds are much more available than CT scans in many parts of the world. But if you had to ask yourself, when does an ultrasound outperform a CT scan for a patient with abdominal issues? And there's two diagnoses, cholecystitis and ovarian torsion. What is the unifying feature of these two diagnoses is that the pathology is in one specific point, literally point, where there's an obstructive gallstone in the case of cholecystitis, and when there's a twist in reference to ovarian torsion. 1 point. If you can point to the origin of the disease process with your finger in a case of abdominal disease outside of acute trauma where you see blood, ultrasound is superior to CT. If you cannot point to the disease process, then odds are your ultrasound will be a helpful screening test to say, wait, is there a problem? Which it did. But then to really understand the nature of that problem, you need a CT scan. And what could a CT scan offer you here? It allows you to understand this image with higher quality, but also, and most importantly, it allows you to broaden your gaze and say, does this person have diffuse disease in their belly, or is this just in the liver? For example, if this patient has extensive lymphadenopathy, you're not going to see that on ultrasound. So, from a practical standpoint, if you're choosing between ultrasound and CT, you would choose a CT unless you have confirmed case or high suspicion of cholecystitis or um, or ovarian torsion. There are some people who say that kidney stones is also a focal issue that you can point to. There's some complications about using ultrasound to detect kidney stones that have to do with accuracy of actually visualizing the stone, and that's a conversation for another time. So what am I thinking here? Or earnestly, I'm thinking, oh gosh, we definitely found a lead to follow. Let's study that lead in more high quality imaging, but also let's not pretend that we have a good view into the entire abdomen. What if the patient has multifocal disease and we haven't appreciated that multifocality yet? All right, Lucas, very, very intrigued. What do you have for us next?
I have to say, I did forget the TTE.
Oh, that's okay.
Sorry.
No.
Just TTE said left ventricular hypertrophy, normal left ventricular ejection fraction, no wall motion abnormalities, but some diastolic dysfunction, and severe aortic valve sclerosis without significant stenosis. So if you want, you can comment on that, or I just give you the next aliquot.
I think there's a very good reason you forgot, which is I think it might not be a powerful clue to this case, as Siva has already outlined. But I appreciate your earnest presentation of all the data in real time. But yeah, I think for the sake of time, I think there's a lot of juice left in this case. Why don't you tell us the next outcome?
Okay, so the next aliquot is the ultrasound and the course after that. So the ultrasound read was for the liver. There were several lymph nodes present at the porta hepatis. For the biliary system, the gallbladder itself is no longer identifiable. There is a conglomerate measuring approximately 7 by 7 centimeter with liquid components and a 3 centimeter shadowing calculus. Common bile duct is 5 millimeter, and intrahepatic ducts are standard. So after that, the patient was started on Sozin and some IV fluids and got admitted, where his renal function improved. down to a creatinine of 1.3, but his leukocytosis and symptoms persisted. He remained hemodynamically stable at any time, and given ongoing symptoms and leukocytosis on day 5 of admission, a CT of the abdomen and pelvis with contrast was performed, which again, I would like you to share some pictures if you're okay.
Please. Please, I'll just share that, Siva, I think it's a great time to look at these pictures and then go into breakout rooms to have everybody kind of put their thoughts together. So let's take a look at this picture. Maybe you and I can take a crack at analyzing it, and then um, amazing. Okay. Wow, fascinating. So yeah, Siva, what are you seeing here?
I can see the liver mass
Yeah,
with like a calcification in the corner. And
excellent. Yeah, I think that now that everybody's seen it, let's go. I'll pause the recording, and then let's go into some breakout rooms for people to. All right, welcome back, everybody. So, Siva, what was the conversation like in your room?
in my room, we are thinking about like the mass. It is more like a gallbladder mass, something like that.
Sure.
So we talked about cholangiocarcinoma,
Very
and
good.
then we talked about like it can be like an indolent infection going on from a while.
Yeah. Yeah,
So yeah, that's what we thought. And yeah, the patient is pretty inflamed at the moment. So
agreed. Agreed. Yeah, I think that. Well, I'll share with you that I think the pertinent negatives in this case are the patient does not appear to have any cirrhotic morphology to his liver, and there is only one large dominant mass as opposed to multiple different masses. There also doesn't seem to be any other abnormality outside the liver itself, including in the gallbladder, which is nice and decompressed. Um, Sibyl, I'm really curious just to dissect with you. How long do you think that large calcific process has been there for?
I from a long time, like 1, 2 years,
Yeah, right.
something like that.
Right. Yeah, I think that we're used to seeing gallstones we're used to seeing biliary stones in the gallbladder in the extrahepatic biliary tree, but there's an entity called hepatolithiasis where you actually get stones in the intrahepatic bile ducts. Similar pathophysiology to getting it into the extrahepatic bile ducts. It's very rare. But when I saw that CT scan, I was trying to figure out, is this a disease of the hepatocytes, which we do with the labs quite well, or is this a disease of the bile duct cells? And the presence of that large stone is very, very suggestive that the disease is actually within the biliary system, not the hepatocytes. Of course, this could be the rare possibility of HCC with calcification, which is described. But the lack of a cirrhotic morphology of the liver really reduces the probability of HCC. Alternatively, as Ravi just mentioned in the group, whenever you see the possibility of calcification, you have to think about echinococcus. The thing that reduces the probability of echinococcus from the data that I know is presumably the lack of travel history in this patient, though we don't know that. But more importantly, the fact that it's in the left lobe of the liver. Both entamoeba and echinococcus predominantly affect the right lobe of the liver. And so that's a little bit less likely. And so I think you outlined the key tension. This is very likely there's a stone. The stone suggests biliary, and the question is, what are the biliary issues we have to worry about? And so the two biliary issues that we have to worry about are that this is hepatolithiasis, and there's a stone in there. And what has that done? And I think the most concerning thing it has done is something you've already said. Chronic hepatolithiasis is a nidus for cholangiocarcinoma. Cholangiocarcinoma can and often does occur with no clear risk factors, but a big, big risk factor is biliary inflammation, primary sclerosing cholangitis, chronic pigmented biliary stone. So I, like you, worry about the possibility that this stone, this chronic intrahepatic hepatolithiasis stone, has begat malignant transformation and might be cholangiocarcinoma. Alternatively, and more likely, there is now a pyogenic liver abscess around this stone, and that liver abscess is not making progress and needs to be drained. And those are the two hypotheses, which you already narrated. So I think you probably need to sample this thing. It's large enough that you can do so and you hopefully will find bacteria. And if you find bacteria, you hopefully can drain it and the patient's done. But if you don't find bacteria, you're in trouble because it might be because you gave the patient Zosyn and sterilized the cultures, or it might be because the patient has cholangiocarcinoma. So if I'm drawing a visual schema for you, needle plus bacteria, yay, good, treatable. Needle, no bacteria. Ooh. Is it treated abscess from Zosyn or is the patient have cancer? But even if you actually successfully treat this thing and there is bacteria, you can't rule out the possibility of underlying cholangiocarcinoma. And so I think the case will have to proceed with treating this entity, with draining all this fluid, hoping you find infection. But even if you find infection, underlying cancer can't be excluded. If you don't find an infection, that doesn't mean there isn't one because you gave the patient antibiotics. So this is all very murky area, but I think the two main diagnoses here are more likely infection versus cancer. The main wisdom that I can try to impart upon you is the fact that when you see a stone like this, you usually see it in the gallbladder, as you said. Uh, Stone formation can happen in the liver. It's called hepatolithiasis. It usually localizes the disease to the biliary system, and the same dreaded complications of the biliary system apply. Infection or cancer. I hope it's an infection, but it may be cancer or both. Any questions or reflections on that, Siva?
Dr. Ravi, I mean, does this hepatic lithiasis, does this patient have to have any kind of vulnerability underlying,
Excellent
or
question. Excellent question. It's such a rare disease. I don't think we know about it. I certainly don't. I think I think the answer is no, but I say that with hesitancy because I haven't studied this space in years. The only thing I know about this space is from an image that I saw in an image challenge a long time ago. So this case is really, it was such a dramatic image that it was hard to forget, but I certainly forgot everything about it. So I encourage all of you to read more about it. But I will throw out what I think I know, which is that I think it can happen with no clear risk factor, similar to biliary stone disease in the larger bowel duct.
got it?
We have a lot to learn. So Lucas, tell us what happened.
Okay, awesome discussion. You get the CT reading, and the CT reading was that the gallbladder and biliary tract is no longer clearly identifiable as a distinct structure. Instead, a lobulated, multi-septated conglomerate mass is visualized within the gallbladder fossa and the porta hepatis, extending into the liver segment 5. This process measures approximately 9.3 by 8.8 centimeters in the axial plane and contains a centrally located 4 times 2.5 centimeter calculus. And the next aliquot will reveal the diagnosis. And yeah, what do you think?
Interesting. Very, very interesting. Yeah, Siva, what did you think about that information?
Yeah, I'm on the same boat, like as you said, like a stone in the liver, maybe a biopsy, to see the tissue might help. But I
Hmm.
have one question, like how much do you think of a granulomatous disease going on right now in this patient? Is it something that we can
Yeah, very fair.
put in the differential or not?
Yeah, very good question. You know, I think the error in my reading of the CT scan is I thought I saw the gallbladder as a distinct entity, but I was wrong. And so the update in our knowledge of this space is that you can't see the gallbladder. So you
Hmm.
start to have to wonder, is this the gallbladder? And is the gallbladder behaving in this way as a result of a mechanical obstruction by the stone? Or, alarmingly, is this a gallbladder carcinoma with or without an underlying infection? So I think the pathway is clear. I think most structural issues in medicine need histopathological clarification. Um, I think the probability of a granulomatous infection is low simply because granulomatous infections cause multifocal disease. So a more classic presentation of a granulomatous process would be that the whole liver is replaced by a granulomatous infection like TB or Histo. when the disease is so dominantly in one specific location, it often is a pyogenic infection or a malignancy. I think if we can't see the gallbladder, then I think we have to assume this is the gallbladder that we can't see. And it seems to be, unfortunately, an invasive gallbladder process, which might be a really bad obstruction from a stone that has caused the gallbladder to behave this way. Alternatively, a gallbladder carcinoma is super rare, um, but I think an invasive behavior like this certainly raises concern that this patient might have gallbladder cancer. But I think the next step, unfortunately for this patient, is likely to understand this at a more granular level with histopathological analysis. So what would I do in real life? If I would get on the phone with the surgeons and see how can we address this? And I would be really open to learning from them because I don't have the expertise to try to decide, do we try to biopsy this? Do we try to see if we can take this thing out? So there's a huge knowledge gap for me and lack of expertise in how this is addressed. So I'm really, really curious to learn from Lucas. Any other thoughts, Stefan, before we learn from Lucas what happened?
No, nothing. Thank you so much.
I had a really, really interesting case, Lucas. Yeah, Mike, to you.
Okay, so the results of the CT scan and the clinical picture were most concerning for an acute on chronic cholecystitis with contained perforation and abscess formation. So because of that, he underwent CT-guided drain placement, as you said, Rabi, with microbiology revealing E. coli, Klebsiella, and Enterococcus faecium. And following his symptoms improved and his leukocytosis resolved. He later underwent cholecystectomy to assess for underlying malignancy and for definitive management of his symptoms with pathology revealing acute and chronic phlegmonous perforated cholecystitis with extensive scarring consistent with acute and chronic xanthogranulomatous cholecystitis, which I had never heard before.
Amazing. That's so cool.
There was no evidence of dysplasia or malignancy. And following a complicated post-operative course, he ultimately made a full recovery. So what do you guys think?
I have so many thoughts. Oh my gosh. Wow. Well, my real earnest thought is I'm so happy for this patient. My second thought is I think that you are embodying the value of presenting common diagnosis with a twist. This is not some rare fancy schmancy. This is final diagnosis, acute on chronic cholecystitis. Everybody has heard of that here. And the journey to making that diagnosis is so topsy-turvy and complicated. I'm really, really grateful for you presenting it. Siva, what were your reflections on this case?
I am glad this is not cholecystitis. The patient is good. But
Yeah.
yeah, it's a lot of learning. Yeah, thank you
What
for
did, what did it feel like to discuss it?
yeah, it is good. I was nervous in the start, but later it felt good to discuss. Like I can clearly know where my knowledge gaps are, what things I need to fill in.
Yeah.
So it is a good experience.
Yeah, I mean, I think that your ability to disentangle signal from noise is really, really powerful here. And I think if I were to offer in a reflection about when this case starts to, yeah, just as linear reflection is what you said earlier, Siva, about there's some structural problem here. Most subacute structural problems, especially in a patient without fevers and chills, is cancer. The most powerful moment in this case, I think, is when you have a platelet count that's high. That starts to open the door to the idea that the patient has an infection instead. And what kind of infection does he have? It's absolutely fascinating. And it goes to show you how you need expert radiologists. Because if I were the radiologist, I would have called this an intrahepatic stone. But they're like, no, no, no. This is the gallbladder going in the wrong direction, which is really illuminating. And I think you're seeing such a powerful consequence of what happens when you have chronic obstruction with a massive stone like that. And if you borrow from the kidneys, which we brought up earlier in the discussion about ultrasound versus CT, the kidney story of this disease is very well described, where you have a chronic stone, a struvite stone often, that causes recurrent acute pyelonephritis, but also causes an entity called xanthogranulomatous pyelonephritis. And it is the idea, basically, that when you have such chronic low-grade infections, your macrophages react akin to what you just said, granulomas. They start to form these xanthogranulomas, which are yellow pigmented granulomas, have a really cool biology behind them. But it goes to show that when you cannot contain a pyogenic infection, you start to make a granulomatous reaction. So I have never heard of the gallbladder version of xanthogranulomatous disease, but I've seen the renal version of a kidney stone do this exact same thing over and over again. And so I find this case really, really illuminating. Really grateful to discuss with you, Siva. I thought you did an outstanding job. And Lucas, what an emphatic first case. Really, really appreciate you presenting it. I'm curious what reflections you have.
So I saw the patient primarily in the emergency department. I did the primary evaluation and the ultrasound, and when I was doing the ultrasound, I was like, "Oh, that looks very bad." And I got my colleague, and she did an ultrasound, and she wasn't clear. And so very many people did an ultrasound on this, and it was not very clear what the end result was. And I have to be honest, Alec and Vale, awesome physicians who very supported me through the case, and even the end diagnosis, because I didn't pay so much attention to the pathology report, but Alec did, and Alec had so many questions about this case. And I like reiterated the case and was okay, this case is so different than what I wanted to present. And so the end diagnosis and the mechanism of xanthogranulomatous cholecystitis wasn't clear at the beginning. And I learned that you have a biliary obstruction, it was increased intraluminal pressure, then those Rokitansky-Aschoff sinuses, there was leakage, and there's so macrophages plays a role. And it's actually a MIC disease. So as you said, cancer versus infection. And this is exactly the problem, because when you don't catch this diagnosis, you resect, for example, too much as a surgeon in the operation, which you don't have to, but it's very hard sometimes to make this diagnosis. So it's a great mimicker. And again, a big shout out to Alec and Vale, especially Alec, because he really took me by the hand and made this case completely different than I expected. I was like, 10 minutes, no problem. I can present. And he was like, wait. So awesome, terrific guy, awesome physician. Many thanks. And yeah, thank you that I could present this case.
You know, Alec is known for his humility, and I think you made him blush so hard he'll never turn his camera on for the next year, maybe. Thank you. He's a legend of the space, and I think you're becoming one as well. So kudos to both of you. Huge shout out to Magnus for scribing. Thank you so much. Siva, I still am really in awe of how you were like, ignore the heart, ignore everything, and really focus on the problem. And I think you did an outstanding job today. Mike, to you, Julia, for the teaching points.
Friends, you took my breath again, and being aware of the time, I kind of want to summarize the case by giving a big shout out to like Alec and Lucas, to really show us how important curiosity is and trying to understand the problem here and how can real passion for medicine can lead to such diagnosis. I think that's a big learning and a reminder for me in this case. I think the details are summarized and you can probably read them out better, but what I also took away, just to always try to distill clues and signals from any noise and consequences. And I think you both really showed us how to do so, and that led us to narrowing down on our differentials. Um, just to mention maybe one or two teaching points, what I really loved is paying attention on the labs, try to have a separate view from our history and just being able to um, draw consequences that the labs can really be a mark of chronicity and lead us uh, to the right path to diagnosis. Um, I think I'm really excited to read more about Santogonodomatous infections and the mechanisms, and lastly I would love to mention the great comparison you made, Rabih, between like the renal pathology and the liver one, because um yeah, it's just yeah, so much learning. Thank you guys.
Oh, thank you. I hope I see some of you 15 minutes before the VMR so that you can stare at a beautiful smile from Jas. In fact, I'm going to put a picture of him as our center show for tomorrow. Thank you, Lucas, for an awesome case. Thank you, Siva, for top-notch discussion, and Magnus and Julia for really, really supporting the session. Appreciate you all. See you later.